and we'll start off. Our program is entitled Individualizing Oral Antiplatelet Therapy to Optimize Outcomes in Patients with Acute Coronary Syndromes. And here you see the learning objectives. My pleasure to now introduce Dr. Matthew Rowe to speak about a critical look at guideline recommendations and patient and condition-specific needs in individualizing oral antiplatelet therapy.
Thank you. So thank you for the introduction, and we'll get started here. And this will be the first of 3 different presentations on the bigger topic already presented. So I think it's pretty clear that we understand at least the platelet cascade and how thrombus formation takes place along with the coagulation system. So there's platelet adhesion, then there's activation of platelets, and many different substances can be involved with that, as we've already learned in the past. And then there's aggregation of platelets that will form that part of the thrombus that's developing. Now, there are many different pathways involved, and you can see here that a number of different agents will stimulate platelet activation and aggregation, ADP, thromboxane A2, many other factors as well. And it's a rather complicated system. And as you can see in red, the P2Y12 receptor is involved with this. There are many other receptors as well, and we'll focus a lot of our discussion today on P2Y12 inhibitors because those are the class of drugs with the newest amount of data available, and I think we've been using aspirin for so long, there's probably not a need to go over all the historical data regarding aspirin. But it is a complicated system, and there are other targets that have been investigated, such as the PAR1 antagonist that we won't go into great detail today because those agents are not approved in practice guidelines. So when you look at the different part of it. So there are 3 approved and available P2Y12 inhibitors. Ticlopidine is a historical agent that could also be in this class, but because of toxicity reasons, it's really not used at all in practice these days. Clopidogrel is the longest running agent. It's a thienopyridine, as is prasugrel. Both prasugrel and clopidogrel are irreversible inhibitors of the P2Y12 receptor. Both are prodrugs that are activated after metabolic steps, whereas the metabolism of clopidogrel has a 2-step conversion. Prasugrel is a 1-step and is quicker and have a fairly long duration of action once patients at steady state because of the irreversible nature of the binding of the receptor. Ticagrelor is a reversible agent. It has a shorter onset of effect and also a shorter half-life, but has fairly intense platelet inhibition. So once the drug is withdrawn, it still takes up to 5 days to recover platelet function when you're preparing for an elective surgery. So we'll go through a number of different guideline recommendations. Here, this dashboard is similar to a stoplight, in that green is a recommended guideline therapy, a class 1 recommendation. Red is class 3, which means it's not recommended. And we'll talk about treatments for both patients with unstable angina and non-STEMI, shown in this slide, as well as patients with STEMI. And one of the foundation strategies for unstable angina and non-STEMI recommended by practice guidelines is an early invasive strategy. And we'll next talk about how antiplatelet therapy goes along with that. But an early invasive strategy, meaning an angiogram within 24 to 48 hours, is recommended for unstable angina and non-STEMI patients who have an increased risk for clinical events. And there's a whole host of factors that go into this risk calculation: elevated troponin levels, S2 segment depression on the EKG, refractory chest pain, other things that we know, prior revascularization, hemodynamic instability, etc. But this strategy is not recommended for patients who have extensive comorbidities or those who don't consent to procedures. But an early invasive strategy does not ensure that the patient actually undergoes revascularization. That is a decision made by the treating physician based on the angiographic finding and all the clinical findings of the patients. This strategy indicates that they get a diagnostic cath, and then other things will happen based on the anatomy and other factors. So these are the different things that determine risk that I mentioned. Other things: heart failure, sustained arrhythmias, a high risk score such as the TIMI risk score, the GRACE risk score, which integrates many factors, or known reduced LV function. Okay, so let's go to the first question. In your practice, what proportion of patients with non-STEMI do you estimate will undergo angiography with subsequent revascularization, meaning either PCI or CABG after undergoing angiography? 1 is greater than 75%, 2 is 50 to 75%, 3 is 25 to 50%, and 4 is less than 25%. Okay, so it's a fairly even distribution. So most would estimate, at least 2/3 would estimate that more than 50% of their patients will undergo revascularization. The other group is in below 50%, but it's fairly evenly distributed across the 4 answers to this question. So that's, I think, by itself an interesting finding. So let's see what actually is happening in U.S. practice right now. And these are data from the Action Registry Get With the Guidelines, sponsored by the ACC and the AHA, evaluating patients with both STEMI and non-STEMI in more than 500 U.S. hospitals. So most of these hospitals are invasive centers who have cath and PCI capabilities. And in the cumulative period of 2012, 80% of patients with non-STEMI in the U.S. at these hospitals did undergo a cath. Most of those patients underwent a cath within 48 hours, and then the use of PCI was 49%. Among those patients, most had PCI within 48 hours, and 10% underwent bypass surgery. And if we look at trends across the quarter, they're relatively flat, and across years, if I were to show it that way, it's relatively flat, and that is that roughly 50% of patients in the U.S. will get PCI with non-STEMI, 10% will get CABG, and the remainder will be managed medically. And that means they either underwent a cath and no revascularization was done for a variety of reasons, or no cath was done at all in the first place. But these trends are relatively flat, and they're not increasing with time. So the next question is, what is your standard practice for the timing of initiation for the loading or initial dose of a P2Y12 inhibitor for a patient with positive troponin levels that confirm a non-STEMI? So let's presume this is a patient who was not taking a P2Y12 receptor inhibitor at home. So the first answer is in the ED as soon as the troponin values are known to be elevated. Number 2 is in the CCU once the patient has been evaluated by a cardiologist. 3, in the cath lab before angiography starts. And 4, in the cath lab, but only after the decision to perform PCI has been made based upon the angiographic findings. So this gets to the question that Dr. Libby was addressing earlier of the different differences in where these agents are started. Okay, so the majority actually would say in the ED as soon as the troponin values are elevated, and then 32% say in the cath lab once PCI has been confirmed. So we see, kind of a variety of usage patterns. I think this has changed over time. Initially, we were seeing very little use of P2Y12 inhibitors in the ED because of concerns about patients who may need to undergo CABG if they were loaded with the therapy. And then I think we also see differences by hospital, and there have been some analyses of this published recently from registries like the Action Registry Get With the Guidelines. So if we look at the guideline recommendations for antiplatelet therapies during the acute setting, so in the first 24 hours, for patients with unstable angina and non-STEMI, as I mentioned earlier, aspirin is recommended for all patients, and I think that's pretty well understood. For those patients who are managed invasively, so you're planning to perform a cath in that early time frame, before PCI or cath is performed, both clopidogrel and ticagrelor are given a 1B recommendation, meaning they have been tested in that upstream setting. And then at the time of PCI, if the agent was not started beforehand, clopidogrel, ticagrelor, and prasugrel are recommended because certainly the patient would need that therapy before undergoing PCI. In contrast to clopidogrel and ticagrelor, prasugrel has only been shown to be beneficial when used at the time of PCI for patients with ACS, so it is not recommended in the upstream setting. And then for those patients who are managed conservatively, either no cath or a cath without revascularization, both clopidogrel and ticagrelor are recommended for up to 1 year. Now, I'll just briefly mention anticoagulants. I know you had a session on that beforehand, but these are part of the treatment strategy along with antiplatelet therapy. So for patients managed invasively, unfractionated heparin or low molecular weight heparin are given a 1A recommendation. Fondaparinux or bivalirudin are given a 1B recommendation. Typically what we see is bivalirudin is used in some patients, but only in the cath lab and not in the upstream setting. And in the United States, the majority of patients will get unfractionated heparin. And then for conservative management, all these agents are recommended, but there may be more consideration to use a longer-acting agent like a low molecular weight heparin or fondaparinux. And so next we'll go to the STEMI population, and the question here is, what P2Y12 inhibitor do you use most commonly to treat a patient with STEMI who's undergoing primary PCI? And this would be, we're not asking the timing of it, just which one would you prefer to use. Number 1 is clopidogrel, number 2 is prasugrel, and number 3 is ticagrelor. Okay, so the majority are still using clopidogrel, and I think this is what we see when we look at the registry data as well. And 14% would prefer prasugrel and 10% would prefer ticagrelor. So if we look at the guideline recommendations for STEMI, these also kind of overlap with the PCI guidelines. So they're all integrated in this slide. They have similar recommendations. For patients in whom primary PCI is planned, which is the preferred strategy in the United States when it's readily available, a P2Y12 receptor loading dose or inhibitor loading dose is recommended as soon as possible. Clopidogrel at 300 to 600 milligrams, prasugrel at 60 milligrams, and ticagrelor at 180 milligrams. And it's interesting to note that none of these are 1A recommendations because, for example, clopidogrel has never been truly studied compared to placebo in the primary PCI setting, and prasugrel and ticagrelor have only each been studied in one trial, so that's why there's a 1B recommendation. And then anticoagulants are recommended as well. Again, as we said earlier, both unfractionated heparin and bivalirudin are given recommendations for use during primary PCI as shown here. Now, when we look at the use of acute medications in the ACTION registry get with the guidelines, and we compare and contrast STEMI and non-STEMI patients, focusing specifically on the P2Y12 receptor inhibitors, we don't have data yet from the use of ticagrelor, so we can profile clopidogrel use and prasugrel use. And here we see that 63% of the STEMI patients get clopidogrel, 28% get prasugrel. Some will switch, so these numbers are not mutually exclusive, whereas 47% of the non-STEMI patients will get clopidogrel and 9% will get prasugrel, and total use is shown on the right. So there's far greater use of early P2Y12 receptor inhibitors in the STEMI population linked, I believe, to the use of primary PCI compared to those with non-STEMI. Now, it's also important to understand aspirin dosing because this goes along with the use of these P2Y12 receptor inhibitors. And the guidelines specify based upon the type of stent that was implanted or whether a stent was used at all, what the aspirin dose may be. So for patients with unstable angina non-STEMI who have a bare metal stent, 162 to 325 milligrams of aspirin is recommended for a month, followed by lower doses thereafter. For a patient with a drug-eluting stent, same dose of aspirin for up to 3 to 6 months, followed by lower doses. And for medically managed patients, lower doses throughout. Now, it's interesting that in most every other country besides the United States, lower doses of aspirin are used from the beginning throughout the whole treatment course with good results, but we still embrace higher doses of aspirin in the United States, which clinical trials would indicate there's probably really no difference in terms of ischemic events, but maybe a higher bleeding risk with higher dose aspirin. And so when we think about the ACS patients and we think about anticoagulants, oral antiplatelets, IV antiplatelets, and then the cath strategy, there are a lot of different combinations that could be chosen, so it does get to be somewhat confusing. And one of my colleagues who put this slide together calculated that there are 144 different combinations. So it can be confusing, but I think we do have good evidence that we've tried to present from the guideline recommendations today. And I think when you think about what therapy you'd like to use, obviously the type of event is important, whether it's a STEMI, a non-STEMI, or an unstable angina event. The type of practice patterns and availability of procedures. So if you're at a center that's geographically isolated and has no cath lab, then your initial treatment strategy may be different than if you practice at a center that has immediate cath lab availability. Also, what is your formulary, and in the long-term setting, what is covered by the patient's insurance plan. And then we look at patient factors such as ischemic and bleeding risk and trying to balance those two in terms of optimizing the most effective and safe treatment strategy. Renal function is important, and then obviously cost to the patient and their estimated compliance over time. And it's also important to note we're trying to mitigate the risk of adverse outcomes. Here we can only show in-hospital outcomes in this registry, and we can see that for STEMI patients, the risk of mortality is higher in the in-hospital phase, but many studies have shown that after hospitalization, after about 3 months, that risk changes and is higher for a non-STEMI patient. There is still a risk of transfusion and bleeding, and that has gone down with time as we focused on proper dosing of adjustable antithrombotic agents, but still we could reduce it even further. And when we think about this long-term challenge of preventing ischemic events, reducing the risk of bleeding over time and maintaining compliance, we have to think about how long would we use a P2Y12 receptor inhibitor in these patients. So for STEMI, the guidelines recommend for those who receive a stent, which is the majority, use of these agents for at least 12 months, irrespective of the type of stent that's implanted. For unstable angina and non-STEMI patients, 12 months is recommended for patients who are stented and those who are managed conservatively. Also, those who have bypass surgery should receive one of these agents upon hospital discharge. And there are differences in the use of the agents, as I mentioned earlier. But the guidelines do specify that if the risk of bleeding with sustained therapy outweigh the benefits, earlier discontinuation may be considered, and there are studies comparing these different durations right now. And at discharge, when we look at the use of these different therapies in the STEMI and non-STEMI population, there's similar use of clopidogrel at discharge, higher use of prasugrel in the STEMI population, and higher overall use of P2Y12 inhibitors in the STEMI patients at discharge. Do you believe that a P2Y12 inhibitor should be administered to a patient with non-STEMI who will be managed conservatively without revascularization, so without PCI or CABG? Answer 1 is yes for all patients. Answer 2 is yes, but only for those patients who undergo angiography, have confirmed disease, but do not undergo revascularization for some reason. And answer 3 is no, that there's not indicated for this type of patient. Okay, so the majority would recommend treating all patients, as the guidelines indicate, for those who manage conservatively, even if they haven't undergone an angiogram for whatever reason. And so just the last few slides, the use of these therapies at discharge is very different for the non-STEMI population. So the PCI patients, the vast majority will get a P2Y12. Medically managed patients, only 55% will receive that. And then the bypass surgery patients who've had a non-STEMI event, they're ready to go home, their bleeding risk from the surgery is done, they're not prescribed a P2Y12 receptor inhibitor commonly upon discharge. So when we talk about individualizing oral antiplatelet therapy, there are multiple options that are now available in the peri and post-ACS setting. Aspirin is a cornerstone therapy. We have 3 different P2Y12 inhibitors, clopidogrel, prasugrel, or ticagrelor, and we've talked about the evidence and the recommendations for each of these agents today. However, the risk and benefits of each agent and the combinations need to be considered. Certainly, we think that high-risk subgroups such as the STEMI population may benefit more from the more potent P2Y12 inhibitors, prasugrel and ticagrelor, but we have to be worried about bleeding risk, and there's certainly a lot of concern about causing excessive bleeding with these agents, and so we weigh those balances against each other when making treatment decisions. And the maximum recommendation of therapy for a P2Y12 inhibitor post-ACS is 12 months, but longer durations of treatment are being studied in ongoing clinical trials that we expect will be reported next year. So we look forward to seeing those results, and we may have future evidence to share with you regarding longer durations if those trials turn out to be positive. Okay, so thank you for your attention, and I'll ask Dominic to come for the second presentation.